Hello, everyone, and welcome to our channel. And today we have a new session about clinical pharmacology and clinical therapeutic. Our topic today about anemia, antiplatelet, and anticoagulants. This session focus on the flashcard that enhance knowledge retention, uh, understanding the material, and help to apply the material and also to maybe enhance active learning. Let's get started. Start first with the definition of anemia and the classification. WHO, World Health Organization, defined anemia according to the blood test, and men hemoglobin uh, considered like in men suffer from anemia if hemoglobin less than 13 gram per deciliter, or in women less than 12 gram per deciliter. Classification according to the MCV, we have microcytic, macrocytic, and normocytic. So the question here about what are common causes of anemia here. Here we're talking about microcytic anemia and mostly related to the iron deficiency, thalassemia, or could be related to the macrocytic anemia related to the B12 deficiency or folate deficiency. Another name, megaloblastic anemia. Sometimes we see normocytic anemia due to the acute blood loss or chronic disease. Iron deficiency anemia, here that we have low MCV, low ferritin. So the situation here, microcytic anemia related to the low MCV and low ferritin related to the microcytic deficiency anemia. Often we see that due to the blood loss. Vitamin B12 deficiency, most common to see it after surgery on the stomach, gastrectomy with neurological signs. What type of anemia we are going to see there with the B12 deficiency? B12 deficiency causes megaloblastic anemia. So megaloblastic macrocytic anemia due to the B12 deficiency. And here when we have this gastrectomy, the surgery, this will lead to the pernicious anemia due to the lack of intrinsic factor. Okay, so speaking about drugs and medication here, as you can see here, we have ions, we have oral, available like oral, IV, absorption, and we are going to speak about toxicity. So from the next coming slide, we are going to speak about pharmaceutical form. Is this oral? Is this IV, which mean intravenous? Or we are going to speak about absorption and toxicology of the FE. Okay, in this slide here, they ask about a list of oral iron salts used as first line in iron deficiency. We have ferrous sulfate, ferrous gluconate, and ferrous fumarate. Name of IV iron preparation. We have iron saccharose, ferric carbomaltose, iron dextran, sodium ferric gluconate, ferromexylitol. How to enhance absorption of ion, or how to decrease absorption of ions. So we have some factors may enhance absorption and other factors reduce absorption. So we enhance absorption of ion by increasing gastric acidity, by using ascorbic acid, for example. So we have two options: increase gastric acidity and use ascorbic acid, which is vitamin C. Ion absorption may be decreased when the patient use antacid, calcium, dairy product like milk. If the patient take tetracycline for acne, for example, treatment, or for other infectious disease. Here we talk about two type of ion available. We have ferrous, we're talking about Fe2, and then we have ferric, Fe3. Ferrous, Fe2, is like easily absorbed more than the ferric. Okay, the question now: who's the end candidate for the IV ion instead of oral ion? Okay, if you have someone suffer from intolerance of uh, ion, oral ion, of someone suffer from malabsorption, which mean dysfunction of absorption from the GI system, someone suffer from significant ongoing loss of blood loss, for example, and suffer from severe anemia, we need to intervene IV. Suffer from irritable bowel disease, CKD, chronic kidney disease, or like perioperative need, end-stage renal disease, and then we can prescribe it like tube nutrition supplementation. Who's the most appropriate, or what is the most appropriate antidote for acute iron toxicity? If someone, for example, take a 20 or 30 tablet iron by accidentally or by mistake, how we can treat this patient with acute iron toxicity? The antidote for this case will be the furoxamine. The furoxamine considered like parenteral ion chelator. Okay, moving to the next important elements for anemia, we have vitamin B12 and we have folic acid. Another name for vitamin B12, cyanocobalamin, and folic acid considered like vitamin B9. Okay, what causes pernicious anemia here? So here we talk about another type. We have, when we talk about iron deficiency, we were talking about microcytic anemia. When we talk about B12 deficiency or folic acid, in this situation, we are talking about macrocytic or megaloblastic anemia. We have another maybe subtype division or subtype called pernicious anemia. What causes of pernicious anemia here? Pernicious anemia is like autoimmune loss of intrinsic factor from the parietal cells. When you have injury or damage, this will lead to the impaired or decreased absorption of vitamin B12 in the terminal ileum. Okay, key neurological finding of B12. If you have someone suffer from B12 cyanocobalamin deficiency, what is the clinical findings here? The patient may suffer from paresthesia, gait balance problem, disturbances, memory change, risk of irreversible damage if untreated. So it's very important to intervene and treat the patient. Okay, why not given folic acid alone and pernicious anemia? Why we need B12 with the folic acid? When we have someone with a suffer from pernicious anemia, we need to prescribe both medication, folic acid and vitamin B12. It can correct anemia, but worsening a progression of B12 neurological injury. It's recommended when we have someone suffer from pernicious anemia to start a treatment with the B12 first, or we can start together B12 and folic acid. Folic acid uses beyond deficiency. Do you have another uses for folic acid? Yes, we can use folic acid during pregnancy to prevent NTD, neural tube defect, or spina bifida, to prevent spina bifida. Folic acid could also mitigate anti-folate toxicity when you use methotrexate for as anti-cancer drug or for treatment of psoriasis or treatment of rheumatoid arthritis. It's recommended to use folic acid to prevent megaloblastic anemia. We use folic acid for someone suffer from malabsorption. Okay, next agent in the anemia topics, we have erythropoiesis. Erythropoiesis stimulating agent. This agent produced from the kidney. Okay, erythropoiesis stimulating agent. How this medication work? This medication again produced by the kidney. This medication stimulate or induces erythropoiesis and promote reticulocyte release from the bone marrow. We have two medications in the practice. We have abutine alpha and darbutine. Indication for the erythropoietin stimulating agent therapy. Okay, we use this medication, we use this drugs for patients of from anemia due to the uh, chronic kidney disease, CKD. For patients maybe undergo chemotherapy induced anemia, we use erythropoietin. Some chronic inflammatory disease anemia such as rheumatoid arthritis and multiple myeloma after iron repletion. Okay, so adverse effect could be noticed by use erythropoietin, hypertension, increased blood viscosity, headache, seizure, iron depletion due to the rapid production of red blood cells. So this one related to the side effect of erythrobiosis or erythrobiotin. Okay, we're done with the first part of hematology, moving to the antiplatelet. Okay, this will conclude our first session about hematology, clinical pharmacology of hematology, and we cover anemia. The next session will cover antiplatelet drugs, and the last one will be anticoagulant and fibrinolytic agents. Thank you for watching and have a great day.